Hi, and welcome to episode 20 of the Unpacking Weight Science podcast called Evidence-Based Practice, More Than Just a Literature Search. I'm your host, Fiona Willer, weight-neutral professional development dietitian, academic and size acceptance advocate. Our learning goals for today are: identify the three key components of evidence-based practice as defined by Sackett, develop an awareness of the use of PICO and GRADE frameworks in appraising the evidence base, and appreciate the contextual drivers of weight-centrism in existing practice frameworks, including the nutrition care process. Every person who offers health services these days is at pains to tell you that they're evidence-based practitioners or that their services are evidence-based. It's become the phrase people rattle off if they're trying to convince you that they're not full of crap or that their product works, kind of like using scientifically tested. It sounds good and technically isn't a lie, even if the scientific evidence is a small mouse study from 1978 that tested one of its ingredients in your cocktail of woo supplement. For the consumer, those words are meant to give them some kind of assurance that the thing works in the way that you're saying that it does, whether it's a sham wow or new weight loss surgery technique. However, for the practitioner who actually cares that they're offering real evidence-based care, not just marketing platitudes, evidence-based practice comes with a framework and includes far more than cherry-picking convenient studies. And evidence-based practice isn't that the services offered are evidence-based necessarily, it's that what you offer uses the system of evidence-based practice. Unfortunately, the way that I so often see the term evidence-based is in the description of a treatment as a justification that it's not BS. But that treatment is not going to be the best clinical choice in all circumstances, and neither is it necessarily going to suit the preferences of the client who's considering it. When the term evidence-based is used in this context, it just means has been shown to have more of an effect than a placebo in our possibly narrow and ungeneralizable clinical trial. You might also mean scientifically tested. There are loads of supplements out there claiming they've been scientifically tested, which the public interprets as tested for effectiveness, when really the only scientific testing that they've been subjected to is toxicology tests, checking that they won't kill you immediately. So what is evidence-based practice then? One of the foundational contributors to the development of the evidence-based practice framework is David Sackett, who writes that the fundamental principle of evidence-based medicine, and by extension evidence-based practice, is the integration of good evidence with clinical expertise and patient values. Your notes have a diagram which show this division. We've got three components leading to evidence-based practice, and without all three, evidence-based practice is not occurring. Firstly, the research evidence coming in from one side, competence of the clinician to provide the treatment from another, and the client's preferences from another again. Gray and Pinson wrote that the most important reason for practicing evidence-based practice is to improve the quality of care through the identification and promotion of practices that work and the elimination of those that are ineffective or harmful. Ackerbang wrote that evidence-based medicine promotes critical thinking. It demands that the effectiveness of clinical interventions, the accuracy and precision of diagnostic tests, and the power of prognostic markers should be scrutinised and their usefulness proven. It requires clinicians to be open-minded and look and try new methods that are scientifically proven to be effective and to discard methods shown to be ineffective or harmful. When we decide after critical appraisal that a piece of evidence is valid and important, we then have to decide whether that evidence can be applied to our individual patient or population. In deciding this, we have to take into account the patient's own personal values and circumstances. The evidence regarding both efficacy and risks should be fully disclosed with the patient in order to allow them to make an informed decision. And this approach allows a therapeutic alliance to be formed with the patient or the patient's caregivers. So evidence-based practice or evidence-based medicine is not meant to refer to what you offer. It relates to how you do things. It's a system that tries to ensure that a client receives up-to-date information about their condition and about their options, not just the things offered by that practitioner, but all the options they may have. That practitioners have good self-competence appraisal skills for their own skill sets and to allow client-centered care in which the client's preferences are front and center. It's a ritual of care provision, not the intervention that the person is offered. So you can see, like all of science itself, evidence-based practice is supposed to be a self-correcting system. It's supposed to naturally lead to reform and progressively more effective, feasible and acceptable care. It's a really admirable aim. But like science itself, biases are abound, not necessarily in the process, but in the questions that are asked by scientists and by clinicians in the first place. So let's step through the process and then take a look at the fat traps. So firstly, you formulate answerable clinical questions. And one way to do this is through a PICO format question, which I'll talk about in a tick. Then you find the evidence and you can appraise the evidence then using the GRADE framework, which I'll talk about. Then you apply the evidence by discussing it with the client, and then do the thing and evaluate your performance. So let's start with the first section, appraising the evidence using a PICO question and then the GRADE evidence to decision framework. So PICO, P-I-C-O, stands for P, patient, problem or population, I is for intervention, C is for comparison or control, and O is for outcome. So with what we're trying to do is make a specific question that's answerable by looking then into the research evidence. So, for example, with the patient, problem or population, you want to define what the target market is essentially. So what are the patient's demographics? So things like age, gender, ethnicity, or what is the problem type? And being specific, something like work-related neck muscle pain. The intervention, what type of intervention is being considered? For example, is it medication or exercise or rest in the case of that neck? The comparison or control group. So is there a comparison treatment to be considered? So that could be another type of the same kind of thing, like a different type of medication, or it could be something altogether like medication versus exercise as the control. Or there might be a control group who's doing nothing special at all. And then outcome. So what is the outcome that you are looking for? Is it relief of that sore neck? Or is it something like quality of life, a bit broader? Or is it something like a biochemical test for cortisol markers and so forth? So in every step of the PICO question, you are asked to be more and more specific about what you're actually after. Now, once you've got your PICO question, you can use the GRADE evidence hierarchy framework to assess the stuff that you've got. So you get your PICO question, you go to research database and you plug in all of those details and see what papers have been written about that specific population, that specific intervention or interventions, and the specific study design, whether it's controlled or not, and the outcomes that have been found or desired. And you've got your bunch of papers, and then this GRADE framework helps you to assess those papers and see which are worth listening to and which are worth discarding. And that's really around evidence, around study design, and around the type of population that it was based on. Is the population that they did the study in analogous to the type that you're interested in? Did they use a randomized control trial? Did they use a control group? Did they use a type of methodology that means that the things that they're reporting are likely to be actually true things, real things, not just figments of statistics? So GRADE, which stands for Grading of Recommendations, Assessment, Development and Evaluations, is a transparent framework for developing and presenting summaries of evidence and provides a systematic approach for making clinical practice recommendations. It basically means that it reduces the risk of accidentally cherry picking. It's the most widely adopted tool for grading the quality of evidence and for making recommendations, and there are over 100 organisations worldwide who officially endorse GRADE. When I've been doing development of guidelines and so forth, I have been required to use GRADE as the evidence appraisal system in that process. So with the GRADE system, we use PICO to narrow our literature search and then go through the literature and rank the relevant papers for quality or level of evidence. So a paper reporting outcomes in a randomized control trial or a meta-analysis of randomized control trials, they're going to be more likely to be correct than a paper that's just written from the perspective of experts, their sort of opinion. It's also used by the NHMRC, and it's the process by which the NHMRC developed that level A evidence statement for the likelihood of weight regain after weight loss. So their PICO question was, how effective are lifestyle interventions in maintaining weight loss in adults? So you've got the population, you've got the intervention, you've got it'll be with or without comparator group, and the outcome is maintenance of weight loss there in that question. And they had a look at the evidence base. They've got a rating for evidence base, consistency, clinical impact, generalisability and applicability in terms of what research papers they found in order to answer their question. And then once they had rated those, and they're all A's except for consistency, which is B, then they derived from that research their answer statement to their PICO question, which was: weight loss following lifestyle intervention is maximal at 6 to 12 months. Regardless of the degree of initial weight loss, most weight is regained within a 2-year period, and by 5 years, the majority of people are at their pre-intervention body weight. So the PICO question allowed them to narrow their search. The GRADE system allowed them to organise their search results and rank them in terms of most trustworthy, and then develop an answer to their PICO question, which summarises essentially the best available evidence for answering that question at the time. So it's quite a cool system, trying to be objective. In 2011, Sackett said that GRADE is much more than a rating system. It offers a transparent and structured process for developing and presenting evidence summaries for systematic reviews and guidelines in healthcare, and for carrying out the steps involved in developing recommendations. GRADE specifies an approach to framing questions, choosing outcomes of interest and rating their importance, evaluating the evidence and incorporating evidence with considerations of values and preferences of patients and society to arrive at recommendations. Furthermore, it provides clinicians and patients with a guide to using those recommendations in clinical practice, and policymakers with a guide to their use in health policy. Following the GRADE and PICO processes as part of the research evidence step of evidence-based practice is not enough to ensure that you get a good idea of the available options for that person. The sourcing of best research evidence can only follow the question that is asked. Asking precise questions is important for precision, but we can't mistake precision for clinical validity. So much work that frames BMI as important is really complete garbage. So the PICO asks you to be specific about what you're looking for. And if your frame is weight-centric to start with, you'll already have missed a couple of steps before you formulate that PICO statement. For example, if you've got a larger person in front of you, you're likely to include their BMI characteristic in your PICO, and as a result, you'll push down a weight loss intervention path for whatever the complaint is. By using BMI category in the PICO, you're actively steering yourself away from a true understanding of the underlying condition and its management, and reinforcing for yourself that weight loss is a key treatment for every condition you see in a larger body person. Your belief in weight loss being the appropriate treatment for whatever it's co-occurring with also makes you more likely to skip the presenting condition altogether and search for effective weight loss methods instead. We also have a tendency to search for good outcomes rather than actively seek out harms associated with an intervention. And this is because we assume that if something is effective, that it must also be good, which is a typical human cognitive bias. So to correct for this, for every PICO you ask, there should be an equivalent PICO for harms or negative outcomes. So PICOs should be set for and against weight-centric and weight-neutral options, like a cost-benefit analysis. Only when you've asked your question and compiled your answers do you then step into discussing the options with your client, and this discussion has to include your capability of providing those service options. If you don't provide the service they would prefer, you need to find someone who does, or upskill in a hurry. So to pull this together, let's take an example of a 50-year-old woman who's presenting for knee pain and who happens to have a BMI of 31. So a typical PICO for this situation would be: in obese adult women with osteoarthritic knee pain, what interventions are effective for improved pain control and quality of life? So you go and do your searches using the GRADE framework to assess the quality of the research you've found and come to a conclusion about effective treatments. Now, precisely because you've put the word obese in the PICO, you'll get an avalanche of weight loss studies in your search results. Because most weight loss studies have weight loss as the only or major outcome measure, you'll get the impression that weight loss was important for the attainment of the things that you're interested in, namely pain control and quality of life, because they're often listed as secondary outcomes in weight loss studies. And if the intervention included strength-related physical activity or changes to diet, including more fruit and veg, which can have an anti-inflammatory effect, or even just a focus on better self-care because they're in the study, they tried to get more sleep, look after themselves, etc., then some of them may well report their pain control and quality of life as higher than before the study. The impression that those papers give is that it's the lower weight that it's the reason for the benefits, rather than the things they were doing at the same time as they were losing weight, the effect of insufficient energy intake itself, or the very fact that they're in a study that says that doing these things will help them. If the PICO instead was, in adult women with osteoarthritic knee pain, what interventions are effective for improved pain control and quality of life? The search results for that PICO will include a variety of interventions not related to weight and that very well might benefit your patient immediately, namely effective pain relief medications, physiotherapy treatment, lifestyle measures, pain management counselling, etc. Options that may have been buried in that previous search or not tested at all in heavier people because we've got this obsession with weight loss as a treatment. Armed with a broader list of options for your patient with osteoarthritic knee pain, she can now choose an option that is suitable for her needs at the time, what she's keen to try, not what you think she should try, and one that she can start right away. In dietetics, we have a practice framework that aims to integrate the steps of evidence-based practice into the provision of dietetics counselling. It's called the nutrition care process. The steps are nutrition assessment, nutrition diagnosis, nutrition intervention, and nutrition monitoring and evaluation. Nutrition assessment involves collection of information and data from the client and investigating the evidence base for the presenting condition. Nutrition diagnosis calls for the dietitian to identify and label the nutrition problem. What will dietetic counselling be aiming to change? And this isn't a medical condition, but might be managing a nutrition-related symptom of one. For example, a nutrition diagnosis isn't diabetes, but a nutrition diagnosis for someone with diabetes might be excessive carbohydrate intake, as evidenced by high blood sugar levels and a diet history showing high carbohydrate intake. The problem with the issue of weight concern in dietetics is that the powers that be in dietetics have deemed obesity to be a nutrition diagnosis rather than a background characteristic, a potential result of another condition or potentially related to problematic eating behaviours. We're encouraged to prioritise clinical presentations over intake or behavioural environmental issues. So when someone presents with all three of those components in play, perhaps they have lowish dietary quality, perhaps they have incomplete or incorrect nutritional knowledge or low food literacy, perhaps they have severe body image issues, but if they have a larger body size, that is what we're supposed to make the priority issue that's going to be fixed with dietetic counselling. Not only that, the intervention step of dietetic counselling is where patient preferences are given space for discussion, but because this happens after the problematization of the person's situation, the options offered will be through that lens. If weight is problematized, then the list of options provided by the clinician, the dietitian, will be weight loss strategies. The outcome measures set as part of monitoring and evaluation must follow from the nutrition diagnosis. So if obesity is the problem, the outcome measure will then be BMI. Our weight-centrism is baked into the way we do things. We need to change the ingredients and modify the recipe here. If, instead, the nutrition problem was prioritised as the context in which food makes it into the person, then we'd have more scope for process goals and social determinants of health-related goals instead of outcome goals. This is the difference between recognising that building self-care habits is an outcome in itself instead of using BMI to prove that strategies have worked. The patient preferences piece of the evidence-based practice puzzle is well expanded in the concept of client-centred care and its process of shared decision-making. This implies that patient self-determinism is a necessary part of healthcare provision. Shared decision-making itself is defined as having three components: the provision of reliable, balanced, evidence-based information outlining test, treatment, management or support options with clear representation of risks, benefits and alternatives, outcomes and uncertainties. Secondly, the decision support counselling with a clinician or health coach to check the patient's understanding and clarify their options and preferences. And thirdly, a system for recording, communicating and implementing the jointly agreed actions. The process of shared decision-making between a clinician and client ensures both informed consent and that at least two of the three principles of evidence-based practice are met: client preference and discussion of the risks and benefits of treatments. Weight concern issues are a good example of what Wenberg calls a preference-sensitive care area, as more than one generally accepted treatment option is available, making shared decision-making critical to the provision of evidence-based care. Dietitians and other clinicians would also benefit from the development of decision aids, which include weight neutral and weight centric options to assist in shared decision making with weight concerned clients. If the clinician is not competent with the treatment approach that the client selects, they would then refer to a clinician who is. I quite like drawing parallels here with positive childhood feeding dynamics, where the patient or carer is responsible for providing a wide range of foods to choose from, and then the child decides how much of what to eat with no coercion. This is from Ellen Satter's work and is summarised in the phrase, "Parent provides, child decides." It's not the job of the parent to get the child to eat the food. It's their job to make enough nutritious and tasty food available. The decision of what and how much to eat is the responsibility of the eater, not the provider. So we can think about our counselling dynamics in a similar way. It's not the job of the clinician to get the client to do anything in particular. We're not the boss of them. Our worth is not related to their outcome measures. It's their job to provide a diverse range of appropriate and effective options, and the client has full autonomy to choose what is right for them at that time. Put another way, the client is the captain of the ship and the clinician is the navigator, who's doing the best for both of them but has incomplete maps. In line with shared decision making should be shared evaluation measurement decisions. How will they know when things are going right? When all we give them is BMI, then we throw the baby out with the bathwater. Instead, goals like physical function, like bowel function, muscle strength, doing things that are personally meaning for them, playing on the floor with the kids, going skating, completing daily tasks with less fatigue, all of these things are meaningful outcomes, and their achievement can be measured using reports of frequency and feelings on a 10-point scale. Telling someone that their past 3 months of getting fitter and stronger and feeling great doesn't count because their cholesterol is still out of range or their weight hasn't changed is unconscionable. The assessment of clinician competence is marred by the usual human biases. The old, "if all you have is a hammer, then all you see are nails" adage. The tendency of health professionals to feel that what they do is effective and better than other things. The tendency to feel ownership of the treatments that we offer, and we don't want to refer someone out of what we perceive as a safe circle of care for our clients. For clinicians in private practice, referring clients to someone else can feel like potential income walking out the door too, but it's something that we must do to uphold ethical principles. It is strange that clinicians are holding so tightly to weight loss focus because even though they recommend it, loads of studies have shown that they're not confident in being able to support people to lose weight. For example, despite venerating weight loss, dietitians have been found to have poor confidence in their effectiveness to elicit weight loss in their clients. And this sense of unpreparedness or limited efficacy is shared by primary care physicians, GPs and nurses, with many studies showing a significant proportion of health professionals deeming the treatment of higher body weight as futile and professionally unrewarding. Despite these negative attitudes and lack of evidence for the achievability of long-term weight loss counselling remains a primary intervention for those with weight concern who present to a dietitian and other modalities for assistance. And there is some evidence that the profession of dietetics is shifting towards a lifestyle approach to higher BMI, where while weight loss is still considered desirable, it's not a focal point of treatment. And this trend appears to reflect a distaste within the profession for recommending restrictive or prescriptive dietary advice. It's too much like a fad or extreme dieting, while continuing to hold the view that weight loss is obligatory, particularly for people with a BMI of more than 30. Paradoxically, dietitians have been found to highly value patient outcomes of improved self-confidence and positive body image, which are directly addressed in weight-neutral non-diet approaches by a process of self-acceptance and self-compassion, while in weight-centric approaches they're prompted, at least in part, through the process and result of body shape change. I would say it 1,000 years, if I could. Body image concerns are a perspective issue, not a body issue. So let's have a look now at the evidence-based practice framework in terms of clinicians whose practice is guided by the Health at Every Size principles. It's really an extension of the clinician expertise part of evidence-based practice. Firstly, it's necessary to be across both weight-centric and weight-neutral best research evidence, and this means to be careful with your PICOs and honest with your grades. I can hear people thinking, literally, who has time to do all that? And I get it. But the client should be participating in the process, even in the best research evidence part. Ask them, what would you like to get out of this? What do you want to happen? Feel better, understand their condition more, reduce their risk of chronic disease, control their blood sugars, run around with their kids or grandkids, etc. And ask them what kinds of treatments they've heard about or found online or tried before. Let their answers drive some of your PICOs. Do some of your searches while they're in the room. Ask them if they hadn't come to see you, what do they think they would have tried? Include some research into those options as part of your process. If you don't talk about these things with people and they find the ideas being spouted by the keto devotee in their mother's group and who happens to be more compelling than your advice, even though they have a completely different health situation going on, then you know what's actually going to happen, right? A huge gift that we can give our clients is the skills to appraise the evidence for themselves. In every first semester, first year subject I've ever taught, the first lecture includes where to access reliable information, what sources to trust more than others, how to distinguish who is a credible voice in the deafening din of nutrition discourse. We need to give this gift to our clients too. The clinician competence part for weight-neutral service providers includes not just your clinical skills, but also the prerequisite that you own your own shit. You know your baggage and you're proactive in having clinical supervision and peer support to check yourself. This really should be part of all clinical services, but it's especially important when you're doing body work. It also includes practicing your informed consent discussions and having resources for the clients to take away, and educational and discussion aids for conversations regarding weight. I love teaching people about evidence-based practice, and I hate seeing it misused, misrepresented, and misunderstood. To wrap up, we've covered the components of evidence-based practice, that is, combining best research evidence with clinician competence and client preferences. Ideally, the client is involved in as much of the process as possible, and the clinician recognises that they're far more than an advice-giving automaton. That clinicians' unique qualities and baggage are in the room with the client too, and shouldn't be under the impression that they're invisible or unimportant. We've seen that providing evidence-based weight-neutral care comes along with its own responsibilities due to the practice frameworks that we have inherited and are compelled to operate within. True evidence-based practice asks us to discard ways of doing things if they're ineffective or harmful. So let's set our sights on dismantling those weight-biased systems and frameworks too. So that's it for this episode. The supporting materials, which include the show notes, research links and self-test quiz, are available upfront for current subscribers, only $5 a month, bargain, or can be purchased in a bundle if you're catching up later. See unpackingweightscience.com for details. And next time, episode 21 is overeating, cravings and other nonsense eating terms. The pathologization of body weight and eating behaviours spills out into well-known, often used, but ultimately meaningless terms. This episode takes you on a trip into the research involving the shaky ground of overeating, cravings and binging. Until next time, goodbye.